Hi, my name is Dr Chidiebere Agbakwuru, and I'm a radiation and clinical oncologist working at the NSIA-LUTH Cancer Centre. In our center, we are proud to say that we've come a long way from trying to come to terms with the burden of pediatric oncology to actually now treating pediatric oncology, collaborating with other centers. And as a matter of fact, we're going forward to starting a curriculum for an observership in pediatric oncology. So I'm here today to talk about the treatment options for pediatric oncology. I can't talk about that without mentioning the common types of pediatric cancers, because that's an area where most people, even the health specialists themselves, don't know so much about, talk less of the parents. So the parents need to understand that pediatric cancers are a real thing, and in as much as we aren't out in the open completely about it here in Nigeria, but it's something that has become documented more and more as the years go by. So some kinds of pediatric cancers which are commonplace, I won't talk about the very rare ones, are the intra-abdominal malignancies, the Wilms tumor, and the other types of tumor you can see in the abdomen, where you see your child's tummy getting increasingly swollen up, painful, or you can just see weight loss in the child. You also have different kinds of tumors you can see, like those in the muscles and in the skeleton. You can have bone tumors, you can have soft tissue tumors, you can have skeletal muscle tumors. You now have CNS tumors, those are in the brain and in the spinal cord. So a lot of these tumors can occur, and those tumors usually need the intervention or the input of a radiation oncologist. Now, there are other tumors which we manage with the pediatric oncologists. Those are the oncologists in the Department of Pediatrics, like the non-solid tumors, where they do the essential part of the management and send over to us if they need some of our radiation services. Now, it's important to know that even apart from radiation, which we offer here, there are other types of interventions for children with cancers. The most important one, and the one I like to mention first of all, is observation, because sometimes you can be excessively radical with a child's care, seeing as the child is very young and they have a lot of time to take on board all the risks and factors that will affect them later in life as a result of your treatment. So observation is very crucial. Sometimes you might have a tumor that isn't causing the child so much harm, and you might want to wait till the child is older, or you might want to wait to see if the tumor just remains stable, because intervening in a child will have its consequences. You can't intervene in a child without either causing some kind of psychological trauma as a result of a hideous scar, or as a result of the radiotherapy you're giving, cause risk of some future malignancy. Or sometimes you give systemic treatment which challenges their organs at such a tender age. And some of these organs don't come into complete full maturity until they're about 3 or 4 years old. So observation is very key, and you can't observe by yourself. You have to work with the other specialists. You have to work with the surgeons. You have to work with the pediatric oncologist. You have to work with the social workers. And also you have to carry on board, most importantly, the parents of these children, because the children cannot make decisions for themselves. So the parents would have to be on your speed dial when you're managing children. So apart from observation, most of the time we collaborate with the surgeons, because sometimes that's the primary mode of care, depending on the area the cancer is located. If it's in an accessible location, like on the exterior part of the body, or in the abdomen where it's causing a lot of compression, or in the brain where it's causing obstruction, you will have to get the surgeon's input. So surgery, a lot of the time, comes into the multidisciplinary play of pediatric oncology. After surgery, we come in, the radiation oncologist. Now, it's important to note that radiation oncology has different areas of interest and subspecialties. You have some oncologists who are interested in genitourinary cancers. You have some who are interested in gastrointestinal cancers. And there you have us. We are interested in pediatric radiation, which is even more testing than just regular pediatrics. So you have the grievances of regular pediatrics and that of oncology put in one. So it takes a lot of dedication and affection for children to delve into this specialty. So we have to determine, first of all, what are the indications of radiotherapy for this child? Because more than in any other age category, you have to justify why you're giving ionizing radiation to a child. You're either looking to cure the child, or you're either looking to give some very great benefits to the child. And you have to have evidence to show that this is why I'm doing that. It has to be documented, because the spirit of medical legal issues just lurks over the area of pediatrics. So that's important to note. Then, of course, some cancers need systemic treatment. This is why I talk about our ongoing collaboration with the pediatric oncology department here. Now, giving chemotherapy in children is way more difficult and technical than it is in adults. And while the children tend to be more resilient in terms of their blood work and their ability to regenerate and recover, they also tend to be very tender, and they have a longer spectrum along the age distribution to have the side effects from the treatment you're giving. So it's important to note that, and that's one of the reasons why we have the pediatricians administer this treatment and work with us on it. Now, in terms of pediatric radiation oncology, like I said earlier before, it was something that several years ago we were trying to come to terms with the morbidity and the mortality and the numbers, because a lot of centers were sending these patients to us. So thankfully, the head of the pediatric radiation oncology unit, Dr. Chidiebere Agbakwuru, has worked with several international organizations and other centers to give us the resources and the training that we need to understand what needs to be done for children and to tailor the care of cancer patients specifically to this age category we're talking about. So what are our numbers since till date? If you look at our charts and our data, which I can't put out now, you would see that there's been an steady increase, more like, in the numbers of patients we've been treating. And you would see that this year alone, from the first half of this year to the middle of this year, we treated about 50-something patients with radiation. And of course, you have varying outcomes. You have situations where you have excellent response. You have situations where you just have a stabilization of the disease. And sometimes you have situations whereby you have to go back to the MDT table and discuss what the failures were and look at how to go forward from there. So it's important to see that it's something that's become a mainstay in our practice, and that's what is leading us to try and chart a path into the curriculum so that we have some observership programs and trainings for interns and doctors and even medical students who want to chart a path into the pediatric radiation oncology stratosphere. Because it's not something that can be managed only by a small team at the NSIA-LUTH. I can imagine what will happen if all the centers in Nigeria start sending all the cases of pediatric radiation oncology to us. It will be very burdensome, and I think we will start to have diminishing returns. It would be wrong to say that pediatric radiation oncology started at the Department of Radiation Oncology LUTH without mentioning the pediatricians in their different subspecialties. We work a lot with the pediatric endocrinologists to help us, because a lot of the time hormones are very crucial in children, and when you give treatment, you have to be sure that they don't have any hormonal deficit which will affect their growth and their maturity. The pediatric endocrinologists, the pediatric surgeons, also the social workers and the psychologists who have helped to ensure that these patients have a peaceful and uneventful stay throughout their treatment and a very, very boisterous recovery. It's also important to talk about the anesthesiologist, because we work with anesthesiologists a lot. It's crucial to have a child remain calm and still, which is quite difficult to obtain in children who are under a particular age. Children who are not cooperative, we might have to have a bit of mild sedation for them. So we have an anesthesiologist team that works with us regularly. They are always available to afford us their skills. Sometimes we just use some play therapy, and sometimes we have to do actual sedation of children. But along the line, as the treatment goes on and the child gets used to the exposure to the machine, most of them have been taking off anesthesiology input and they remain calm and cooperative. So last thing I want to talk about is the fact that our team here at the NSIA-LUTH consists of everyone from every division and department here. So we have the radiation oncologist. The team is headed by Dr. Chidiebere Agbakwuru, myself, Dr. Chidiebere Agbakwuru. We have radiation therapists, Mrs. Badejoko. We have our physicist, Ms. Notsurat, and we also have the nurses who are always willing to help us with rehydration of these children, and the psycho-oncologists who help to ensure that little issues with psychiatric health and mental health doesn't set in children, either younger children or adolescents. Now, it's important to note in closing that radiotherapy always has to be justified. But when it is justified, we have the capacity and the techniques to deliver world-class care at the NSIA-LUTH Cancer Centre. Thank you.